Oh, I like the way the hush fell over the room. So, good morning, everyone. Welcome to Panel 2, Building Research Capacity by Engaging Communities. My name is Jaye Clement. I am the Director of Community Health Programs and Strategies here at Henry Ford Health System, and it is my honor to be here to moderate the panel today and to introduce our speakers. I have to say before I actually go into the introductions, everybody has disclosures on the panel because I've been knowing two of the panelists for more than a decade, which in my very short life is a long time. And these three panelists have all worked together on a project abroad in the past as well. So actually with Angie and Barbara Israel, I met both of them through the University of Michigan. Go Blue. And the work that they do through the Urban Research Center. And it's going to be interesting to hear more about the things going on locally and abroad, how they involve community engagement. For us at Henry Ford Health System, as you all know and can imagine, it's very near and dear to our heart. We have a lot of different types of projects that we are building off of and leveraging the work that we've learned through folks like Barbara about community-based participatory research and just community building and community organizing overall. We have neighborhood-based coalitions, a variety of stakeholder engagement activities, the patient-centered research that happens through the health system, and my favorite, which is community health workers, which I'm sure will come up in a way or two as these presentations go on. So, without any further ado, I will welcome Angie and Barbara up to the stage. They'll have about 20 minutes to do a presentation, and then I'll introduce Diego Lucumí. He has a lot of words in his introduction, by the way, that I'm going to stumble over. He'll have 20 minutes as well, and then we'll do a moderated question and answer with the audience for about 20 minutes, and then we'll go to lunch. So I will start with Angie. Angie Reyes is the founder and executive director of the Detroit Hispanic Development Corporation and a founding board member of the Detroit Community Academic Urban Research Center, better known as the Detroit URC. She is actively involved in a number of Detroit URC-affiliated partnerships, examining and addressing, for example, the environmental triggers of childhood asthma, the social and physical environmental determinants of cardiovascular disease, the factors influencing air quality in Detroit, and capacity building for and translating research findings into policy change. She has been active in community organizing efforts in Southwest Detroit for over 30 years. Ms. Reyes is the recipient of several awards, including Court Magazine's Michigan's Most Influential Hispanic Leaders, New Detroit's Closing the Gap Award, and the Detroit Metropolitan Bar Association Liberty Bell Award. Your shelves must be mighty full. Ms. Reyes is known nationally and internationally as a consultant and speaker on issues affecting the Latino community, including cultural awareness, youth gangs and violence, immigration, and education reform. Dr. Barbara Israel is a professor in the Department of Health Behavior and Health Education at the University of Michigan School of Public Health, where I graduated. And then I lost my place. Dr. Israel has published widely in the areas of community-based participatory research, community empowerment, evaluation, stress and health, social networks, and health inequities. Dr. Israel has extensive experience conducting CBPR in collaboration with partners in diverse communities. She is the founding director of the Detroit Community Academic Urban Research Center, established in 1995, which involves multiple funded research and intervention projects aimed at increasing knowledge and addressing factors associated with health inequities in Detroit. She is actively involved in several Detroit URC-affiliated community academic partnerships, examining and addressing, for example, the environmental triggers of childhood asthma, the social and physical environmental determinants of cardiovascular disease, and capacity building for and translating research findings into policy change. Please help me welcome Angie and Barbara.
delightful to be here, and I just want to thank Jaye for that wonderful introduction. I want to thank the organizers for bringing us here, and first and foremost, thank Angie Reyes, my long-term friend and colleague, for co-presenting with me today. And I'm also, it is sort of ironic that both Jaye and Diego are former students of mine. When they were asking us to do this panel, they said, there'll be an international person on the panel with you. I said, oh, great, you know, and they didn't disclose who it was till after Angie and I had both agreed to do this. And then when I found out it was Diego, I was on Diego's dissertation committee, and Angie and I both had the wonderful opportunity to go to Bogota and do some work with Diego. So it feels like this nice homecoming. So again, delighted to be here. So our purpose is to talk a little bit about, and very quickly, some of the rationale behind and the purpose for using a community-based participatory research approach to addressing health inequities, and then some of the definition principles. And then we want to give an example from one of our work. We'll say a little bit about the Detroit Urban Research Center, give an example of one of our partnerships, and then end with some of the benefits of using a CBPR approach. I will say that even though I grew up in the South, I've never been accused of talking too slowly, so if I start talking so fast you can't understand what I'm saying, raise your hand and I'll try to slow down. But we have a lot we want to cover, and I tend to get talking faster when that's the case. So let me just start with, figure out where this thing is here. There we go. Oh no, where's the text? Oh, I didn't know this was animated, so we'll just make it work. So let's just put it all up there. Okay. This is not news to you, and our morning speakers did an excellent job of framing this as well. So, but there are a number of stressors in the social and physical environment that are associated with poor health outcomes, and these stressors include neighborhood conditions. In the work and in the neighborhood conditions that we do in Detroit, this includes lack of access to healthy, affordable food, safe places to be physically active, exposure to violence, exposure to poor air quality, illegal dumping, poor conditions in the built environment. So again, things that are very familiar to us all. But the burden of this disease is borne by low-income communities and communities of color. At the same time, really importantly, is there's an extensive set of skills and resources that communities have to address the issues and these neighborhood conditions that they face. Historically, research has often not directly benefited communities, and in fact has often harmed communities, the Tuskegee syphilis study being, of course, the most well-known. We've heard a reference earlier today about parachute models. It's certainly been used to talk about research, where researchers parachute in, get the data, and leave. I've never quite understood how you leave if you come in on a parachute. But, so one of our community partners, the phrase they refer to is drive-by research. That metaphor I can certainly understand well. The communities are most impacted by health inequities have been the least likely to be involved in the research process. And this has resulted in an understandable distrust of and reluctance to participate in research. But it's not just been research that has had some of these challenges. Public health interventions have often not been as effective as they could be, because they're not tailored to the concerns and cultures of the participants. Rarely have they included participants in the design and implementation and even deciding what the issue is that people want to work on and how to do that. And many of our interventions have focused solely on individual behavior change with less attention to these broader social and structural determinants that we were talking about. So as a result of this, unfortunately, from my perspective, there have been increasing calls for more participatory and comprehensive approaches to research. And there have been increasing support for such partnership approaches. A lot of NIH funding now requires that it be done in partnership. Foundations are often more and more asking for partnership approaches. Actually, foundations have been at the forefront of promoting this work. And community-based participatory research, or CBPR, which we'll refer to, is one such partnership approach. I want to emphasize here, CBPR is not a new approach to research. CBPR builds on decades of history of participatory research, participatory action research, much of which was carried out in Africa, in Latin America, in India, and again, is not a new approach, but builds on that work.
Sorry. Sounded like Halloween there, speaking indoors. So I'm going to talk really briefly about what the definition of CBPR is from our perspective and what some of the core principles are of CBPR that we apply through the Detroit URC. So obviously it's a research that is a partnership approach, but really is about an equitable partnership that involves all of the partners in the decision-making process and the research process from the very beginning all the way through to the end. The community-based participatory research, means that communities have an equal voice with the academic researchers, that we're all able to contribute our expertise, that as Barbara had mentioned, that the community also has expertise in a number of different areas that the academic research may have and may not have, and vice versa. So it really is a sharing of the expertise from all the different partners with shared responsibility and ownership, which means, and again, starting from the very beginning, that it really is that the community is identifying what are the issues that they want to have researched in their community, what are the issues impacting that particular community, and helps to enhance the understanding of what the research is and what's happening in a community by integrating all of the knowledge from the different partners. So a lot of times the people who live in a community have a much better idea of what's happening there from their own lived experience that can help to contribute to what's happening with the research and how it's designed. Again, some of the principles of CBPR that we have used that guide our work is that it first looks at communities as a place of strength, and so it's an asset building approach. So instead of looking at communities as places where there just are problems that have to be solved and that somebody else has to come in and solve them, it looks at the fact that those communities already have strengths and resources that exist there, even if they may not be visible at first to people coming in from the outside, and then builds on those things. Then really promotes this collaborative and equitable partnerships, as I was mentioning before, is that the community really is involved in helping to identify what the research issue and question is going to be from the very beginning, and helps to address the issues that are in the community through designing what that research is going to look like. It facilitates this whole co-learning of capacity building on both sides. So there are things that academic researchers are bringing to the table that can help the community build their capacity, but there are also some things on the community side that can help those in the academic setting build their capacity. So it's really a co-learning that goes back and forth. So there are things like cultural competency, or what are really the conditions in the community, or in some examples, there's things like folks like myself who run organizations have to do a lot of things related to staff. So we have to hire, evaluate, sometimes fire staff that sometimes people who are in academia don't always do. So sharing that kind of learning across both parties is really important. The balancing research and action for mutual benefit of all partners, so that all of our CBPR projects involve some sort of intervention and action, and in many cases policy change. So it's not just research for research's sake. We only had one project where we did just basic research at the beginning, but the understanding was that that research would be used later on to inform an intervention. So there's always some sort of action involved that is directly benefiting that community where the research is occurring. That disseminates the findings to all partners and involves them in the dissemination so that that information is going back to the community. That's one of the biggest concerns in many communities, is that researchers leave and we never find out what was it that they discovered. Is it going to help my community? Is this information that we can use to benefit our community, or is it something else? So making sure that we know, and the community knows what those findings are, but also that we're involved in the dissemination ourselves so that it's an equitable thing. So it's not just the academics talking about what those research findings are. We always do this in partnership with each other. And as you can tell, this promotes, it's a long-term process and commitment. So it goes beyond just one research project. Not very few partnerships have lasted 20 years. My standing joke is that the URC partnership has outlasted both of my marriages combined together. But it does take a long time with building that kind of trust and relationship between the academia and the community partners. So this is something that there's a commitment to stay with it beyond that initial research project. So this is a continuum that shows various levels of community involvement in research that are possible, starting all the way to, from your left, where it's pretty much just investigator-driven. Community has no involvement whatsoever in any of the research aspects, to where there's research happening in the community, so they may be collecting data and conducting surveys or focus groups in the community, but the community wasn't involved in deciding what that research was going to be or any interpretation of that data or sharing that research. To having the community involved in some decision making at some levels, all the way to CBPR, which we're talking about now, where it's an equitable partnership with community and academic partners, to community-driven research, where some community organizations develop their own capacity to conduct research. So they're doing it without academic and outside researchers. So it's really along that continuum. This is briefly some of the partners that are involved in the Detroit URC, which was mentioned that it started in 1995 with funding from CDC to start partnerships with community and academic partners. Since then, we've received funding from a variety of different sources, both foundation and federal funding, to continue the work. We work in multiple communities in Detroit. Started out by working on the east side of Detroit, which is predominantly African American, and the southwest side, which is predominantly Latino. Some of our work now is expanded to other parts of the city of Detroit, like the northwest side of Detroit, but it is really looking at conditions within the city of Detroit. And there are 8 community-based organizations that are involved in the partnership. Our local health department, so Dr. Saeed, who spoke in the previous panel, is one of the members. An integrated healthcare system, actually we're sitting in it, it's Henry Ford Health System. And then several units of the University of Michigan are involved in the Detroit URC. And the board is comprised of representatives from all those different entities. Over the years, the URC itself has evolved into be kind of an umbrella entity with several partnerships that are underneath it, which this kind of is our attempt to show graphically what that looks like. The URC itself has had about 30 projects that the URC board has overseen that include the Eastside Access Partnership, Community Action Against Asthma, Racial and Ethnic Approaches to Community Health, or REACH Detroit, Healthy Environments Partnership, which had several sub-projects underneath it, and the Neighborhoods Working in Partnership. And then there are a couple other ones doing a health impact assessment as well in the city of Detroit around the Detroit Future City project. So all of these projects have adopted CBPR principles, but then there are several affiliated partnerships that are under the umbrella of the URC, which each have their own steering committee, many of them consisting with some of the members of the URC board, but also additional members who join that partnership. And all of them use, again, the same CBPR principles and involve some of the same processes that were developed through the URC. So over the years, these are some of the things that the URC has accomplished. So there are benefits to working with community. We've had the 10 CBPR partnerships, over 35 research projects, have received over $40 million in grant funding, have been able to improve the health status of intervention participants, and have built new relationships linking the university and communities between different communities, like I mentioned before, Latino and African American community, as well as between residents in the city of Detroit and the university. And I want to mention that in the $40 million in grants, not all of that went directly to the university. Several of those grants went directly to the CBOs. and then we subcontracted with the university. So we've been working over the years for there to be an equitable relationship even in the funding.
So what we want to do now is just turn to one of those partnerships and just give you briefly a quick glimpse at some of the work that we're doing. This particular partnership is called Community Action to Promote Healthy Environments. So we call it CAFE for short. You know, we're all really good at coming up with these acronyms, right? And I'll just quickly say this, and then I'll go in a little more detail of each of these. First of all, it builds on 3 longstanding partnerships. We aim to increase knowledge about factors influencing exposure to air pollution, translating those findings into developing a public health action plan, then trying to engage in implementing that action plan and evaluating the process and impact. I want to acknowledge my colleagues who are part of the CAFE. Angie and I are both part of it, but Amy Schultz and Stuart Batterman are the PIs, other colleagues at the university. So here are the partner organizations that are part of CAFE. We refer to this is our first foray as a partnership of partnerships. So the Detroit URC is a partner, Community Action Against Asthma, one of our partnerships, is a partner, the Healthy Environments Partnership, and then a number of other organizations. So all of those community-based organizations, Health Department, Henry Ford Health System, et cetera, are part of this entity and this effort. And we're really trying to address issues related to air pollution and health that builds off of work of our affiliated partnership and bring that information together and really do something to bring about change here in the city related to air pollution. I'll say a little bit more about that in a minute. So what's important to us is this recognition that communities bring certain roles and responsibilities and expertise to the partnership, the academic colleagues bring certain roles and responsibilities, and then jointly we work together on some of these in contributing. So from a community perspective, identifying priority action areas, identifying key opinion and policy leaders, developing community and youth leadership. I'm not going to go into all of these, but those are some of the things that our community partners bring that myself as a researcher, I don't know what it's like to live in Southwest Detroit. I'm not a Detroiter. I understand that. And so that's the expertise that's so critical to the work that we do. From an academic side, we conduct background research, we identify vulnerable communities, we estimate health impacts, and do a lot of that work. But then jointly and importantly, we identify what the key priority areas are. We as researchers don't come in and say, you ought to be working on this. That's something we develop together. We inform strategies for synthesizing information. Together, we define the components of our public health action plan. We're getting ready to implement that action plan, and then working to identify funding to continue work on the action plan. So one of our, the first thing, this is a 5-year project. We are in our 3rd year, just finishing our 3rd year, and we've done a lot of work to take research that we'd already conducted around air pollution and asthma, and air pollution and cardiovascular disease. Again, I won't go into all those findings today, but trust me, we have a lot of them. We have a great website that I couldn't say that a couple years ago, but now it is great, that's up and running and can provide you with a lot of that information. So how do we get that information out to the broader community? So one of the things we've done, we've developed a lot of fact sheets. Again, these are on our website. We've identified communities that are experiencing excess exposure to air pollution. Air pollution exposure is not the same throughout the city of Detroit. Southwest Detroit has considerably more exposure than other areas of the city. And again, presenting that information. Identifying vulnerable communities, a subset of mitigation strategies to try to quantify the health and environmental benefits. What can we do to bring about change in this air pollution? And then develop a preliminary set of recommendations. Secondly, and this is what we've been doing over the last year, is developing a multi-level, integrated and scientifically informed public health action plan to reduce air pollutant exposures and adverse health effects. The plan is actually going to come out in January. That's the goal. I think we're going to make it. We're in a process now of having taken all the different research information with the steering committee, trying to make sense of that information, and now we're meeting, we just had 2 meetings earlier this week, with a broader set of policymakers, decision makers in the city and region to look at what we've come up with so far, to look at some of our recommendations in terms of mitigation strategies, and help inform the action plan before we actually present it more broadly. And then our next aim is to actually then develop and implement campaigns, interventions, and policies to promote the recommendations in the Public Health Action Plan. This is not intended to be a plan that sits on a shelf, but rather to implement the action strategies. We recognize we can't do that alone, so one of the things we're doing is developing more extended partnerships with other entities in the city and beyond who are interested in air pollution and health. So, for example, there's the Michigan Environmental Justice Coalition, the Detroit Environmental Agenda. Those partners are part of our partnership, and again, working with them to implement. One of the things I think is important to mention here is that in terms of the role of our community partners, we've been able to get additional funding from the Herb Family Foundation. I should have mentioned NIH funds the overall partnership, but we've gotten additional funding from the Herb Family Foundation, where DHDC is the fiduciary. They submitted the grant proposal along with Detroiters Working for Environmental Justice, another key Detroit partner, and that's going to allow us to do a lot of the implementation work, particularly around youth development, community organizing, the policy education training that we're going to be doing with youth, a mini grant program where we're going to be, people in the city can apply for mini grants to do things in their local neighborhoods to try to, again, mitigate some of the negative impacts of air pollution on health. Just a couple of summary lessons learned on this, and then turn to Angie to close us up with some overall benefits. We've really, that the action to improve air quality of health of Detroit is really critical. Again, people are interested in the data. We'll be glad to share that. There's a large exposed and vulnerable population in the city due to air pollution. There's a disproportionate level of adverse health outcomes that are associated with these air pollutants. And we have an opportunity to improve air quality and reduce health inequities. And that the partnership approach we really feel is critical for being able to do this. Some of our lessons learned include mutually agreed upon principles and process and roles that has supported this environmental justice work. We spend a lot of time talking about how are we going to work together in an equitable way, because if we can't be equitable, how can we propose that in the broader community? We've done a lot of advanced planning and shared values around equity, mutual respect, sharing relationships that we consider to be critical, building off of pre-existing relationships and shared power. We've had a real benefit here that many of the partners around the table we've already been working with for 15, 20 years. And so that really helped us speed up the process, if you will. A commitment to listening and responding. I think I'll speak for academics in particular. We're pretty good at talking. We're not so good at listening. So this has been a skill that's an ongoing one we're working on. And a commitment to strengthen capacity and create opportunities for engagement and decision making. Again, not just with our partnership, but recognizing as we move forward to implement the action plan, we're trying to propose and encourage equitable processes.
So there are a number of both benefits and challenges to doing CBPR, as you can imagine. And one of the things we found is that CBPR is not for everyone. Not everybody should do CBPR. Some folks are really good at doing bench science, and that's probably where they should stay, and that's okay because we need good bench scientists too, right? Some of the lessons that we've learned over time in some of the conversations and discussions we've had between steering committee members, between both academic and community partners, as well as some community partners, have kind of informed what we've learned over the years of both the benefits and the challenges. So first, using this approach really helps to enhance the relevance of the data. Community partners are equally involved in helping to design things like survey questions, even collecting the data. So we've hired community members to collect the data and conduct the surveys, because we know that community residents are more likely to give true answers to surveys when they're people that they can relate to, rather than somebody coming from the university. And also as a way to make sure that the data is actually being collected in a culturally competent and sensitive way. And then the use of the data is interpreting, again, what does this data really mean? And to be able to look at it from the context of the knowledge that we have of our community helps to really inform what that data means in terms of how we're going to be using it. And really it helps to enhance the quality and validity of the research with recruiting community members and making sure that the quality is something that we can use back for the community. It strengthens the design and implementation. Again, there was, at the very beginning, some of our academic partners had proposed having students from the university going out and doing door-to-door surveys, and folks from Detroit said, no, that's not going to work. But helping to recruit members of the community has been really important, and also keeping them in the program. So recruitment and retention is really enhanced by having members of the community actively involved in the whole research design. And then the knowledge gained and interventions that benefit the community are really, really important. And those are things that, again, in traditional research don't always happen. But we're very intentional about making sure that happens in the CBPR approach. Okay, yeah, we're getting the wrap-up sign. We're going to talk faster. Providing resources to the community so that there are people hired from the community. Also, community members who participate in the steering committees get paid a stipend to kind of acknowledge that our time is just as valuable as the academics' time. And then having partners with diverse expertise, helping address these really complex issues, and being able to translate some of these research findings into policy, which has been our more later work and how it's evolved. And then lastly, these are some of the bunch of other benefits that we help to identify about making sure that the research really is applied to issues that are important to the community, and that research can be used in a way that's very practical to the community to improve health in our community, and being able to balance that research with action, which is really important. And one of the most important things is that it allows community members to be the gatekeepers to ensure that that research is not hurting the community, which is one of the reasons why many of us originally came to the partnership not knowing who these folks were who were coming into our community, is that we got involved because we did want to make sure we protected our community. And this really allows us an ongoing mechanism to do that.
And so just in conclusion, I wanted just to prove that Diego was at Michigan. On the far left side, you're going to meet Diego soon. A picture of one of our partnerships. Again, just to say, CBPR is not the only approach to research. There are multiple approaches to research. It's the approach that we consider particularly viable working in communities such as Detroit. We're addressing health inequities. So we look forward to Diego's comments and welcome questions at the end. So thanks.
Thank you for that, Barbara and Angie. Now I'd like to introduce our next speaker, Dr. Diego Lucumí. Got that one right, okay. Dr. Lucumí earned a medical degree in the Universidad El Bosque in Bogota, Colombia. He received his master's in public health from the Universidad del Valle in Cali, Colombia. Okay, I passed my Spanish test today. And his PhD in health behavior and health education from the University of Michigan in Ann Arbor. Go blue, I can't help that. Currently, he is an associate professor of public health in the School of Government at the Universidad de los Andes in Bogota. His research focuses on social and physical factors that contribute to the health and health disparities, with a particular focus on cardiovascular disease in Colombia. In particular, he is interested in understanding these factors and their effects on health in urban contexts in order to design and implement comprehensive interventions. In his work, he has used participatory approaches and mixed method designs. Dr. Lucumí's research appears in several international journals. He has received scholarships and grants from Fulbright, IDRC in Canada, and Colombian institutions. Please help me welcome Dr. Diego Lucumí.
Good morning. Thank you for the kind introductions. And first of all, I want to say thank you to the people in Henry Ford for organizing this wonderful symposium, and also for inviting me to be part of this symposium and to share some of the work we are doing in Colombia. So, my presentation basically has four components. I'm going to start with some briefly context about the Colombia and Quito, some background about the work we are doing, and I will spend more of the time trying to explain this work in specific in Quito, that is the city I have been working during the last 4 years doing this project, and finally some conclusion about this work. So these are some pictures of Quito. I'm going to explain where is the city and some of the general information about the city. First, this is some information, maybe you know something about Colombia, but we have a population of 49 million. Most of the population in Colombia lives in urban areas, and the country is divided in 32 departments, and Bogota is the capital district. The departments are similar, but not equal to states in the US, but are similar. We call this department, we have 32. And it's important to say that we are a mixed country in terms of ethnicity and race. Based on the official information, we have almost 11% of the population of Colombia is Afro-Colombian or black population, and almost 3% is from many of the indigenous groups we have in the country, distributed in many places in the country. And 85% of the population is mixed in general. So that is important because after Brazil and the US, Colombia is the third country with the Afro-descendant populations in the Americas. So it's almost 5 million of the Colombians are black or self-identify as a black or Afro-Colombian. In the country right now, cardiovascular disease is the leading cause of mortality. But in particular, the work I'm going to present is in hypertension, and one of the issues is that we don't know, or we don't have enough information about the social patterns and the social determinants of hypertension. That is an important risk factor in Colombia. 25% of the adults in Colombia, based on the national study in 2007, has hypertension. So it's an important proportion of the Colombian adult population with hypertension. And this is a little background about Quito. It's a city in the west part of the country. It's the capital city of the department of Chocó. This is the population, 100 and almost 20,000 people. And different to Colombia, if you see 92% of the population of Quito self-identify as a black or Afro-Colombian population. So it's a high proportion. Is the area of Colombia with the highest proportion of black population. We don't know, and it's important to say also, this city, one of the challenges is because the city has the highest index of reception of displaced population, and these people usually came to the city because for displacement. It's not something they planned to do. It's something that happened because the armed conflict during the last decades. And we don't know exactly the prevalence of hypertension in Quito, but we have some data about the sub-region where the city is located, and you can see the differences. The prevalence for Colombia is 25, but the prevalence for the Pacific Coast is 38. Also, based on the data we have, the few data we have, we see that the mortality for cardiovascular disease is very important cause, of a leading cause in this city. So the work we are doing basically has two foundational projects. One was part of my dissertation, the qualitative part of my dissertation, where I'm going to explain something about this project. And the other was a project that was funded by Fulbright and LASPAW, because when I was conducting my qualitative research in Quito, the participants, most of the participants say, okay, that is interesting to be part of this project, but we want to see what happens next. We need to use these results for trying to identify alternatives for this problem. So fortunately, I found opportunities to respond to the requests from participants. So in the qualitative approach, or in the qualitative project I conducted as a part of my dissertation, the idea was to examine how local actors frame the role of living conditions in shaping hypertension risks and disparities. This was published this year in the Journal of Urban Health. And basically the idea was to know more how these social actors, members of the community organization, and politicians, policymakers, and people working on the health services and the public health department frames the contribution of the living conditions on hypertension in the city. So based on the participants' perspectives, basically they consider the city has two areas. One, they say, okay, this is the center, that is basically the more traditional area, more urban, where people with the highest socioeconomic status live. And they also consider there are one area that is more isolated or in the periphery, and is new, unknown, is more rural, and is mainly the place on the city where displaced people live and people with low socioeconomic status. And also they say that in this area is responsible for the transformation of the city, and this transformation affects most negatively the center. So they don't have necessarily good opinions about the periphery. But they also identify a shared city. It's a city with that has substandard housing, chaotic and disorganized public transportation, and is unsafe. So there are commonalities between these areas they identify. So one of the challenges was to try to put all of the ideas they provided about how the urban conditions of the city influences the risks of hypertension. So basically, they say there are three main determinants of the hypertension in the city: the high rate of unemployment, the forced displacement, and the unemployed urban space. So to process the marginalization and stratification, they create these urban characteristics that shapes the availability, accessibility, and acceptability of different factors that at the end shapes the more proximal factors for hypertension. So they say this is it's something more complicated that say we need to change this. If we are going to change the context for hypertension, we need to talk about all of these factors as that all of these are structural factors. So the next step was, okay, we know more about the problem, but what we need to do. So basically, I applied for a funding to Fulbright, and they provide a small grant in order to disseminate the results, but also trying to know what alternative could be worked in the context of Quito for addressing this problem. So basically, I start talking with people in the public university in Quito, and based on this, we define to work in the identification of potential stakeholders and organizations social organizations that could be interested in participated in these conversations. And the conclusion was that it would be important to establish a local coalition. So we established a local coalition with 12 organizations, 9 from the community, 2 from the governments and the public university. Right now, the current coalition now has 5 organizations, 3 from the community, 1 from the government and the university. The coalition is established operating rules. One of the goals, the initial goal was to establish or to create an action plan for the short, middle, and long term. In this document, this was the first document that the coalitions developed with the idea to include the goals and the activities for the short, long, and middle term for the work of the coalition. And this is the general conceptual model for the work of the coalition. Basically, the coalition decided to have 3 goals, basically, in this particular case, focus on hypertension, working on prevention, working on control, but basically with the idea to have equity as a core issue for the work we are doing. And with 3 kind of approaches, research, intervention, and training, and with 3 kind of partners, community, academia, and government, and these general approaches for the work we are doing. So, specifically, the project we are doing now is the urban living condition and cardiovascular care and disease in Quito. These are the partners that provide financial funding for this project, and this is the logo, the symbol of the coalition. So this project basically has 3 components. One is the community survey of cardiovascular health and disease in Quito. This is the second component, is the neighborhood observational checklists, and this is the third component, that is basically a qualitative approach for this project. So about the community survey, we started in last year. Basically, the first activity was a workshop that Linda, Christine, and John from Henry Ford went to Quito, and we were working with people for 1 week with the idea to start the discussion about how to conduct this community survey. And then we moved to the preparation activities, to plan the survey, to adjust the conceptual model for doing the survey, to design the questionnaire, and working on the sampling design. I'm going to talk a little bit more about the sampling design and the challenges for doing that. And these are the activities we are doing right now. So this was the goal of the workshop. Basically, it was to engage members of the community, the government, and the academia in the discussion about how we can conduct the survey. We apply a questionnaire before to the 26 participants and after the survey, and we found that the level of knowledge of the participants increased after the workshop. Based on the qualitative research, one of the goals was to identify, Quito has 6 localities, was to identify the better places for trying to understand the social determinants of hypertension. So based on the 2 areas in the qualitative study shows, according to perception of the participants. So we decided to work in the community 3, that is the downtown, and this is the more traditional area, and this locality is locality 1, is a locality where most of the displaced people came in Quito. It's a growing locality. And now we are going to move to locality 6 that is more mixed in terms of the composition of the neighborhoods. So in terms of the survey, something we found was there are some official maps, but not necessarily capture the reality of Quito, in particular in locality 1, that is a growing locality. So the first activity was to go into the neighborhoods, working with members of the community, working with the members of the coalition, with the third community organization in the coalition, people in the government, to see, okay, we need to understand what these neighborhoods are in reality. So these are the work. A student from the university, a member from the community, they were working on this, trying to identify exactly how each of the 26 neighborhoods looks like. So based on this, using these maps, you use these maps for created a sampling framework for the survey. And then we were talking and having a discussion about the components of the questionnaire. So the questionnaire has these 7 components. We are collecting basically for the biological anthropometric measures, systolic and the diastolic blood pressure, information for estimating BMI and waist circumference. So and all of these information in addition. So we have some, we completed the survey last month. So this is something important. Initially, the idea was to apply in community 1 and 3, 522 interviews, but we only got 2,269. So in general, the rate of response was 50%. That was very surprising because in other studies with low-income population in Colombia, usually the rate of response is about 80%. But why Quito has a lower, or at least in this study, is lower. So something we identify is that high mobility, people move very quickly. So between the time we conducted the block listing that was in May to the time we conducted the survey, people move between one neighborhood and another. So we need to understand more what is going on, what happened, what are the reasons. We have some ideas. One is the perception about safety in some of the neighborhoods. So people move because in some occasions they found that the other neighborhoods, maybe the nearest neighborhood is safer than the previous one they live. So, but we need to understand more about the reason why people move so quickly from one neighborhood to other. So beyond the result of the survey itself, I think there are many important lessons about how to conduct this kind of studies in contexts like this. Actually, this is part of the conditions we found in some of these neighborhoods. This was a flooding. This was a flooding in some of the neighborhoods. So our interviewers that are from the community had to work in these conditions to try to get the information. And this is the part of the blog listing. Students and members of the community walking to the neighborhoods to try to see how many houses there are in each of the neighborhoods that were selected for the study. So based on the work we are doing, we can say that we need the adoption of social determinants of health framework for addressing complex problems like hypertension is very important in urban areas like Quito and other urban areas, similar urban areas in Colombia. But basically that is important that we engage multiple stakeholders, in particular people from the community in this work. Basically, for each of the steps, so each of the aspects of this project, we got the advice of people from the community. In particular, those that are most affected by the problems we are trying to address in this context. We recognize that the role of the outsiders is important, but for example, the coalition, one of the rules of the coalition is that only local organizations could be member of the coalition. So external organizations support, but the idea is to create local capacity. So our goal is not to replace the contribution of the local organization. Our role is to support the work of the local organizations for doing what they had to do for addressing these problems at the local level. And these community projects create opportunity for enhancing capacity and engaging different local actors. Something in terms of the methodology is that we need to know more about the characteristics, the particular issues, the particular challenges we face in this kind of community and this kind of urban areas that are growing very fast in the context of Colombia. We need information about what happened at the local level. We need to understand more about the nature and of the health issues because we have pretty good information about the national level, but we don't know exactly what happened at the local level. So we need this kind of studies to understand more about what happened with health issues at the local level. But the collection of information is challenging because, these contexts are very change very quickly. So we need to think in different approaches for addressing these kind of challenges and these kind of problems. So in general, we need methodological innovation for doing this work. We couldn't use the traditional approach for addressing these problems in contexts like this. So this is the team, the people that have been working on this particular project, and this project is part of some of the projects the coalition has for addressing hypertension in the context of Quito. So thank you.
Thank you for that, Dr. Lucumí. We have 10 to 12 minutes for questions, and I do encourage people to go to the microphone for the questions, and I'll take the liberty of asking the first one while people make their moves. So in the framework of community-based participatory research, you've talked about the importance of giving that research back to the community so they have the findings and they can actually use it. So it's literally translating research into action, right? I was wondering if you can do some more translating by sharing a story of your choosing about anything interesting or exciting that you can think of, your favorite story in that process. If there was ever a time where the community interest and the academic interest didn't exactly match up, or any inspirational stories of a really great outcome where you saw community capacity for this kind of work change, just to put you on the spot to say something profound.
Put me on the spot. So actually talking about the cafe project that Barbara was talking about, even though we haven't finished the process, through collecting the research, one of the things that we've been doing is mapping out the vulnerable population within different communities, and also the sources of pollution and layering them over each other, then looking at health outcomes. And that information was really, really useful for a community to share with our director of the health department as well as the mayor. And when the Marathon Oil Company was seeking a permit to increase the amount of pollution they were releasing into the air, and toxins in the air, we were able to share that information with them from community members. And for the first time in the history of the city of Detroit, the mayor challenged a corporation permit application. So Marathon was very surprised. And apparently came with hat in hand to the mayor's office a couple of days later and asked what they needed to do better. So as a result, there's been some negotiations with Marathon about ways they can be better neighbors and start to reduce the amount of toxins they're releasing into the air. And I think that that has been one of the most significant examples of how that's helped.
That was great. Thank you. Did you want to add anything?
I think for me it was when I was conducting my qualitative study, I spent 2 or 3 years trying to understand social determinants and how this works and reading papers. But I remember one on the interviews was a woman she was a former member of the council in the city, and at the end of the interview, say, you explain me something I tried to understand for 3 years about what social determinants of health are. Because it was very interesting the way people in the community can connect something that in the academia is sometimes very complex, but they can say in a very simple way what that means and provide good examples. So I think that kind of conversation are very important and helpful for people that not necessarily, or sometimes we think they are not interested in this issue or they don't have there's enough knowledge for addressing this issue, but they have all of the knowledge. Basically, we need to know for working with them. So I think this is important. And during this work, also I remember when we are talking about neighborhoods with officials from the Department of Planning, and people in community say, no, that is not true. This neighborhood doesn't exist, or that we have other boundaries. We need to make decisions based on what neighborhood means for us, not what neighborhoods are in the official maps. So at the end, we made the decision of following the advice of community and not the advice from the urban planning
Thank you
office.
for that. Yeah, it's great. We'll start right on this side, please.
I'm Brent Williams from the University of Michigan, where I direct the Global Health and Disparities Path for the medical students. I'm peculiarly interested in this phenomenon of funds being directed directly to the CBO, or in the case of low and middle income countries, from NGOs to the CBOs or to the community. Could you all, now you've done it, so could you, and I'm talking to Barbara and Angie primarily, could you just elucidate some of the key success factors, barriers to overcome, pitches, demonstrating value to the university or in giving up this piece of control? How does that work?
To be honest with you, we never asked the university for permission. So that was probably the first thing.
So as the funder, was your
it was
negotiator?
It was a combination of, well, some funding sources, particularly foundations, may not fund the university. They'll fund communities, CBOs. But it was really a decision by the partnership to go after IRB funding, and because then there are several CBOs within our partnership, so we had to figure out who was the best position to apply at what time for what funding. So it really is a collective decision. It was a little bit of the funder was a little confused because it was also complementing federal funding that was going to the university. So some of the funding, it's NIH funding through the university goes to the CBOs, and then some of the money from IRB comes to us, and then we subcontract the university, and they kept saying, so let me try to understand this. The university is paying you, and then you're paying the university. I said, yes. So that we had to go, we went through kind of a process of explaining to the funder how that was going to work, because they didn't understand the role of the university, which is kind of the opposite of what usually happens within research, right? But it really was a collective decision-making process, and finding funding sources that are aligned with the work that we're doing, and that are willing to fund CBOs and the kind of research that we were looking at.
Yeah. Let me just add, thanks, Andy, that was great. A couple things, one of which earlier on, one of our partnerships, the Reach Detroit Partnership, we collectively made a decision because it was federal funding, CDC funding, and they would have funded either a community-based organization or the university as the fiduciary, as the lead organization. It was all there in the RFP. We made a decision, one of our strong partners, CHAS, Community Health and Social Service Center here in Southwest Detroit, was in a position to step up and be that lead organization, and that was a decision, again, the partnership made. That partnership still exists, and CHAS has been the lead fiduciary organization throughout. And, you know, similar to what Angie said, I'm sure the university wasn't happy because they don't get the indirects, right? You know, I was in a position as a tenured faculty member that, you know, it sort of dings me on merit review, but oh, so what? You know, but faculty have to be willing to, and in a position to understand that there are some costs taking that approach. But again, the benefits so outweigh it. Two other points on that. In some instances, we have encouraged community-based organizations or invited, you know, do you want to take the lead on this? And the partners say, no, you know, we're not ready for that, or this is, you know, I don't have the staff to handle the economic, you know, the administrative burden, et cetera. But the main thing, I think, is transparency and opportunity. And the other piece that we've often done is if the main funding comes to the university, are there subcomponents of projects? So again, an example with the Healthy Environments Partnership, we did a youth photo voice project that all of the funding to manage that, to implement it, to carry it out with the youth, Angie's shop handled. So it was a subcontract for a total piece of the research and the intervention, even though the university was the main fiduciary for the overall grant. So just trying to think creatively about different ways to share resources.
We have time for one more question.
I'll try to make it quick. I'm Peter Hammer. I direct the Damon J. Key Center for Civil Rights. One observation is just that you followed the power up to the university, but there's also power in the money for the funding, and kind of thinking through who is setting the agenda no matter how it's being distributed. And linking it to an observation in the keynote about this notion of fiscal austerity and statelessness as being an issue that needs to be addressed in terms of research. What are the effects of that, whether it's through displaced persons in Colombia that Diego was talking about, or if we're thinking about water shutoffs in Detroit. And there's some interesting work in Detroit led by We the People of Detroit to try to document what's not being documented by others. So if you could address this issue of kind of power and the kind of sets of issues that are often off the table, and how collaboratives might try to be pushing the envelope a little bit more on those sets of issues.
It's a great, a great point. I mean, I think the extent to which, I mean, we have done this earlier on with NIH, in that I was part, along with a number of other folks, of we met with NIH institutes and individuals and directors to try to encourage, this was 15 years ago, maybe 20, a more participatory power-sharing approach to research, and changing the way review panels, you know, it's one thing to put out an RFA, but then if your review panel is still people that don't know about power sharing, and, you know, I'm glad to say, I think that, I mean, I know for sure the National Institute of Minority Health and Health Disparities, they came out with an 11-year, 3 different funding stages initiative based on that input that a number of us put on them, if you will. So that's a more national way that we've tried to have that kind of impact.
Thank you. So I have a few housekeeping things to go over, and then we'll thank our panel for today. So next is lunch, and it's going to be Indian food, I heard, which is yummy and exciting, and a change from the dorm. I got a couple from the audience. So that is followed directly by the poster session, which is 12:45 to 1:45 p.m., and all poster presenters need to stand. That's our time. All poster presenters need to stand with their poster during that 1 hour period. As you're walking out, please remember to drop off your project slips, your global health project slips that you got when you came in. It will be your last chance to submit those in the box that's on the back table, I'm told. And then please remember to vote for your top 3 choices after you've viewed the posters. The voting will close at 1:45. The website to do the voting is on the back of the program book. And the third panel is going to start here promptly at 1:45 p.m. So please join me in thanking our esteemed panel.